I'm Debbie Condry. I'm the COO with the Sequoia Project in Carequality, also the CIO and the CISO. And happy to have you all here today. I think what Jonathan might have been lacking in panel size, I made up for that. So we have 5 folks here today who are experts in their field. And I'm really happy and thankful for all of you to be here today. We're going to be talking about a really important topic and something sort of near and dear to me. I came from Sequoia a couple of years ago from many years in state government in Virginia, the last 10, 12 years spent in public health. So as Mickey Tripathi was mentioning to us earlier, the role of TEFCA and how public health might use TEFCA to facilitate interoperability of data is really important and crucial. So the panelists today have expert knowledge in data exchange across the nation, across states and localities. And I think you all have heard enough about TEFCA itself this afternoon, so I won't spend a lot of time on that. I think we know trust exchange framework and common agreement. But one of the use cases is public health. And we want to try to figure out how do we best educate public health and enable public health to utilize TEFCA, the common agreement, qualified health information networks, if that's applicable. How do they use that to better the access to data, the quality of the data, and how they exchange information? I think there's nothing more telling and more timely than where we are right now in terms of coming out, hopefully, of the pandemic and public health learning what they've learned about what they did really well and where there's some room for improvement. And I think one of those things that I've heard along the way, at least, is we need better access to data, or we need more timely access to data. We need ways to do that where we're not creating data exchange agreements that are one-offs. So one of the things that Sequoia will be doing as part of the Recognized Coordinating Entity work is creating a standard operating procedure for public health for TEFCA. So I'm working on that along with some other folks, and we're looking for public health experts as well to work with us on that. So if you're after the panel, if you have interest in that, please let me know, because we'd love to have you provide feedback as well. So I want to start off with the panel and have everybody introduce themselves. But I have a question that I'd like everybody to sort of answer as they're introducing themselves. Jay's like, do you really? And I'm so organized that my notes are on my phone, and I can't forgot my pen, so isn't that good? Okay, here we go. So Jay, if you could please introduce yourself and go ahead and tell us how do you see your area impacting TEFCA? What do you currently do that sort of informs public health and the work that public health does, and how do you see TEFCA sort of enabling that?
Sure, you bet. So hi everyone, my name is Jay Nakashima with eHealth Exchange. We're a network who has publicly signaled that we plan to apply to become a designated QHIN. And we've come a long way with public health since the pandemic. So before the pandemic, we supported Pulse, the disaster response solution for volunteer clinicians to get the information they need to make safe and informed decisions, be it in a makeshift tent or in a convention center or wherever else. We had also started a pilot with for PDMP data to supplement the way that many providers get their access to opioid and other controlled substance data. But since the pandemic, we really hurriedly implemented electronic case reporting. And so this provides eHealth Exchange participants, as well as some of the Carequality networks, the ability to submit detailed clinical case reports to local public health authorities in all 50 states. So these are beginning with COVID, obviously, and MPOX, and then hopefully that list will grow over the years. I think there are 50-some conditions that public health authorities ultimately want to be alerted to. Above and beyond that, we went live on fire at scale back in September. So the FDA is exchanging adverse event reaction clinical data exclusively via fire. So number one, they like to be notified of these potential adverse events electronically via fire instead of via their website or paper mail. But then they also have to query for additional details, and so they do that via fire. The fifth thing that we're doing is we're starting out with a public health fire pilot with the CDC. And that's still in the early days, and we're kind of redefining the scope of that. But it appears that it's going to be related to their ability to collect charts for patients, as appropriate, as permitted by law, related to quality measures. So I do see where these organizations that are brand new to interoperability seem to be often trending towards exchanging via fire instead of via the old or the traditional SOAP, IAHE, CDA way. I'm almost finished. In terms of how I see public health, I think I would echo Mickey. Conceptually, there appears to be a big need in getting the STILTs, the state and territory public health agencies, to be able to exchange among themselves, and then to also be able to exchange with the CDC, and then, of course, with providers.
Mm-hmm. Awesome. Thank you, Jay. Appreciate that. Rachel?
Yep. So my name is Rachel Abbey. I'm with the Office of the National Coordinator for Health IT. I'm in the Office of Policy. And I'm super excited to be here because I think it was like maybe 5 or 6 years ago, it was just a team of us around table trying to dream up what TEFCA is going to be, what it's going to look like, all because of the 21st Century Cures Act. And so now it's really coming to fruition, and it's exciting to see people here that are really excited about it, and I'm also glad that public health has continued to be a part of it. I think, in previous work, public health has been left out of a lot of things, and so I think it's great that healthcare is opening up to public health and including them in a lot of their infrastructure. I think it's important that public health, begins exchanging data, particularly across the United States. Disease does not have borders, and so it's important that public health gets timely, accurate, high-quality data to be able to exchange and to be able to prevent disease and help promote health across the United States. So I think TEFCA is going to be really important, particularly in the building of that infrastructure and the use of that governance. So I'm thrilled to see that happening. So
Rachel,
thanks, Debbie.
thank you so much. Mike?
Mike Sarkissian. I'm the Director for Data and Quality in the Office of Information Management at the Virginia Department of Health. And yes, that is a mouthful, trying to condense that. So in that role, I have quite a few sets of responsibilities, but primarily what we're looking at is we're involved heavily in the data modernization initiative, which we heard about earlier. We have people who are undergoing fire training. So all of these things are really kind of coming together. And as far as the public health role, the thing that interests me the most is public health, at least in Virginia, goes well beyond simply collecting oodles of data about patient care, where they were cared for, so on and so forth. It also includes things like drinking water, emergency medical services, environmental health, all of these sort of aspects that they're part of public health, but they aren't always considered within the realm of healthcare. So I think it's going to be really interesting to see how all of this kind of comes together and plays a role.
Wonderful, thanks.
Thanks, Tim. What was it, Mike? At lunch you said you're like the manager of data management?
Yes,
CDH.
among other things.
Yeah. So hey everyone, Kyle Russell. I'm the CEO at Virginia Health Information, or VHI for short. I'm kind of in the middle of our Virginia-focused sandwich on this part of the panel over here. So VHI is the nonprofit state health data organization for the Commonwealth of Virginia, and we've been that since 1993. Really what that traditionally has meant is we administer a bunch of data systems where administrative data is submitted that's like 6 to 12 months old at least. But we got really good at doing that, and how we influence public health primarily through those systems was in policy. And so whether it was research or policy, different uses of the data where timeliness was not the most important thing, the breadth of the data was, that's where we really shined. But about 3 years ago, via merger with Connect Virginia, the existing health information exchange in the Commonwealth, by merging together and now becoming the statewide health information exchange, that really opened up and expanded quite a bit in what we could do for public health. So for example, 99% plus of public health messages that go to the Department of Health for required COVID reporting and vaccinations, you name it, runs through the Health Information Exchange. And then we also administer the Emergency Department Care Coordination Program, which is really our statewide E&S system that connects all hospitals and plans and other ambulatory providers as well. And so while that's primarily focused on those different groups, it also provides significant benefit to our health department for a variety of different initiatives that they sponsor. So specific to TEFCA, I mean, I'm newer to this, and I'm going to really be in trouble when I can't use that excuse anymore. I've always found like network connectivity and sort of how we fit into the broader exchange like somewhat confusing. And I'm sure there are several in the room here that understand sort of the framework of TEFCA more than I do. But I always felt like it was like the cork board, when they're trying to track the mafia, you got the red strings going in 100 different directions. And so I feel like TEFCA really has the opportunity to streamline that. I'm not saying it's going to be overtly simple, but to really just make it more intuitive and make that more streamlined, to explain how the data flows and how that works to our different constituents and the organizations that we support moving forward. We're really optimistic about that.
Thank you, Kyle. Adam?
Yeah. Thank you, Debbie. My name is Adam Harrell, and I'm the Associate Director in the Virginia Department of Health Office of Emergency Medical Services. And it's nowhere near as impressive as Mike's, but one of the major components of my job is IT systems that impact emergency medical services in Virginia. And that comes into not only our patient care repository, but it's the electronic health record for EMS agencies, the trauma registry, the stroke registry, and many other registries that are fed from multiple different places. And in Virginia, we've had electronic patient care reporting for EMS for about 15 years now. And just before the pandemic, we started looking at this data and we said, we're data rich and information poor. Because EMS collects a lot of data. We adhere to the NMSIS data standard in Virginia, and we encounter about 1.9 million patients a year before they ever reach a hospital or a doctor's office. And we started to see at the onset of COVID that this is very valuable information. And when you start looking at that through the lens of TEFCA, we could start preempting a lot of information. You see things right now with opioid response and detection and alerting programs. A lot of that's coming from EMS-based data. But you can go even farther with that when you start looking at it through the lens of public health. So we started about mid-COVID, which it was probably the worst time to start an IT project, of transitioning the EMS data system in Virginia to where it was more interoperable. And now we have what we call in Virginia the Hospital Data Exchange, where we are automatically linking EMS records to the receiving facilities. But through that, it's a two-way data feed. So it's not only giving data to the hospital, it's bringing hospital and healthcare-related data on that patient back to EMS. And as we continue to grow this, we have started to look at it a lot with TEFCA in mind and the principles associated with interoperability. And again, when you look at it from that standpoint and incorporate that into a system like Virginia's, it's amazing the information that's starting to come out. So, thank you so much, Debbie.
Adam, thank you so much. So you can see we have a panel of experts here. So I'm going to ask a couple of questions, and I want to start with Rachel. So Rachel, what are the overarching challenges that public health is facing nationally? I know that you have 34 minutes.
I know. I know.
Is facing that, and can TEFCA help mitigate any of these challenges?
Yeah, so I won't go, I mean, public health right now in particular are facing huge challenges. I mean, they've, dealt with COVID over the past 2 years. Flu is on the rise. RSV, I've heard that there are other upper respiratory issues. So there's a lot of disease spread currently, not to mention that their systems are out of date. They're resource dependent, things like that. So, I mean, it's really very challenging for them. I will say that, over the past few years, and hopefully I think Mickey might have touched upon this earlier, is that, ONC and CDC are really working together on several initiatives that we hope could help, meet some of these challenges for public health. In particular, we're really looking at it as a huge puzzle, and so there are all these different pieces that we're bringing to the table to help, make the puzzle complete, essentially. And so we have two really strong initiatives. Helios, some of you might have heard in regards to, and then also the public health fire implementation collaborative. And both are really looking at fire in the field and developing pilots and getting public health more on board with fire, how to best utilize fire, what is fire. I mean, we're talking really basic kinds of things with public health. And so I think that's one part of the puzzle. CDC is also working on some shared services that public health can utilize through the North Star architecture. They're developing these pieces or building blocks that will be available to state and local health departments so that they don't need to develop their own new technology necessarily. ONC is also looking at US CDI Plus, which I think many of you have probably heard about. We're looking at specific use cases and data elements and classes that are specific to public health and are outside of US CDI, and so that we can build that momentum and kind of the commonality across public health. And then lastly, I think, CDC is also looking at what's called the Data Modernization Initiative, of which all of these, projects are part of it, but also looking broader at things like workforce development. Public health is desperate for a lot of data managers, folks that can analyze data, things like that, informaticists. And so I think they're looking at those pieces along with resources. How can we sustain this? What kind of resources are needed? And then lastly, encouraging state and local health departments to really how to talk to their public health officials about the importance of data and the importance of data systems and data technology. So, and I think TEFCA overall could really help at least provide some of the pathways for particularly the data exchange, whether it's between health departments, whether it's between providers and health departments, whether it's between CDC and public health. I mean, there are multiple pathways. And so I think, that's where TEFCA is really going to be beneficial for public health. And I think it's great that public health can hopefully leverage this infrastructure and the governance pieces too that follow with TEFCA.
Yeah, thanks. I'm going to throw a little caveat into the series of questions here, so I hope I don't throw you guys too much, but I want to ask a follow-up question on that to my friends at the Health Department in Virginia. Start with you, Mike, and that is, given the challenges and all of the work that's currently going on at health departments, and you can speak to Virginia, but at health departments across the country, where are you all in terms of thinking about TEFCA, and is it on your radar?
So it is and it isn't. I say that it is because data sharing is one of the things that we do a lot of, both inbound and outbound. And that's been true even before the pandemic, but it was especially true during during the pandemic, and it continues today. One of the things that we at VDH were doing even before the pandemic was looking at ways to make that easier. And we were looking at setting up sort of our own version of a trust framework. So in that sense, yes, we're thinking about TEFCA, but TEFCA as its own entity, something fairly new, but definitely something that is going to, I think, help replace some of that work that we are trying to forge ahead on our own, and give us a little more ammunition to help deal with our legal folks.
Yeah, great. Adam?
So from an EMS perspective, before I started working with the Sequoia project, I couldn't spell TEFCA. And I would venture to say that's EMS as a whole. And now it is something that we definitely incorporate into every aspect of what we look at for our information system. Most recently, TEFCA language was used when we were looking at our new vendor that provided our state repository, that they knew what TEFCA was, that they were prepared for interoperability, not just with EMS, not just with hospitals. We're exploring interoperability with health departments, with dialysis facilities, and other entities where the TEFCA framework and language is very beneficial in that. One aspect that was really a driving force with this was at the beginning of COVID. So in Virginia, EMS data is live, it's real time. So we received that within 12 hours of patient contact. So you can imagine from a public health perspective what you could learn about. Law enforcement, for example, in Virginia uses that to identify dealer locations for opioids. So when COVID first hit, everybody knows it was resource issues. There, you didn't have PPE, you didn't have providers. Think about it from the standpoint of an EMS agency. You want EMS to show up when you dial 911. So very early on, we wanted to get positive COVID information to EMS providers so they could plan accordingly when you were dispatched. 911 dispatchers didn't know the signs and symptoms of COVID. So we were trying to figure out ways. About a year and a half into it, we figured out how to do it. But that was a little late. We'd already had provider shortages, loss of PPE. So moving forward, we're trying to make sure that we adopt TEFCA elements to be able to address situations like that in the future should they arise.
That's wonderful. Thank you. All right, I'm going to jump over to Jay and ask you a question. Jay, when you think about TEFCA and public health, how does the eHealth Exchange or national networks in general facilitate public health participating in TEFCA, and what's the benefit?
So I think the federal public health agencies have done a really nice job of reaching out to us and identifying their challenges and then really moving significantly faster than they would have before the pandemic into implementing and getting solutions so that they can make better decisions. Moving forward, they've got a bigger challenge. They've got to figure out how they can replicate this across all 50 states and various territories in a world where the STILTs, the state and territory public health agencies, are really in the driver's seat. So there's definitely going to be an interesting balance there that's going to have to be met.
Yeah, thank you. All right, let's go back to Mike again. Well, Mike, you just spoke. Let's go to Kyle. How do you see HIEs participating in the TEFCA ecosystem, and how might this benefit public health?
I got the one from in advance.
You did.
I think every state is different, right? Everyone's trying to figure out what the approach that's going to work best for them is. And I think for us, we determined really early on that we wanted to partner with eHealth Exchange's QHIN for how we would participate. But I mean, in terms of how we're going to impact public health in Virginia, I mean, I'm just happy it's going to be a better framework even for us just sitting on sort of up on the podium here to share data with one another. I think it's going to vastly improve that and just have more clear standards on, it being responsible for what's flowing in and out of this network, whether it be security standards or what have you. Having more confidence in being able to share that with others, I think, is really important.
Mm-hmm. Let's dive into the idea of security standards and standards potentially around exchanging data. And I speak to this from experience with the health department. So you've seen one health department, right? So I'm going to ask this question of Mike. So how would we elevate the data exchange and the work that you're doing at the health department in terms of data sharing agreements and so forth? How does that get elevated to a national level? And can the common agreement from the portion of TEFCA be helpful there?
I think it can. So a few weeks ago, I was doing some research for another presentation I was giving, and I came across an interesting statistic from the Pew Foundation. Basically said 20% of the American public, or at least the respondents to that particular poll, trust that the government always, or even most of the time, makes the right decision. 20%. Now, we live in a pretty polarized world. It's no surprise to anybody. You're going to top out at around 50% most of the time, if you're lucky. But still, 20% is pretty bad. So trust, I think, is something that we need to build with the public. And so having this sort of framework and implementing the kinds of security standards like we were just hearing about a few minutes ago, and being able to explain to our constituents, our citizens, why it's important that we do that and how those security standards keep their data safe, explain what we're going to do with the data once it gets from point A to point B, who is able to use it and for what. Those kinds of things help to set people's minds at ease and rebuild some of that trust, or at least prevent it from falling even further.
Mm-hmm. And a follow-up question. Would you see public health able to participate in a qualified health information network, so exchange data at a national level?
Absolutely. Mm-hmm. I think, Rachel, I think you said it earlier that their disease doesn't know borders. And so, I was on a call with Arizona not too long ago. Their public health folks, primarily from a data and technical standpoint, but still we were talking about, wouldn't it be great if you had this and we had that and we could just send each other data. Now, Arizona and Virginia, not exactly close together, but, imagine if we could chain all the rest of the states along with that and just start saying, look, here's all this data. Let's make use of it.
Mm-hmm. Great. Jay? Mm-hmm. Kyle mentioned that public health might consider utilizing their state HIEs to connect to public health, exchange data. Would a HIE join a QHIN, and if so, how would that inform and utilize TEFCA in terms of public health? And is public health capable of that, ready for that?
Yeah, great question. So I think it's super exciting. I love the idea of public health moving forward and setting a precedent for other agencies to do the same or something similar. Back when Dave Castle ran Carequality, one of the big impediments to exchange was the purpose of use. So most or many of the EHRs had been hard-coded or soft-coded to only respond to treatment queries. And so there were some emergency measures that were implemented by Carequality to allow, as I remember it, to allow networks to, in effect, request data for public health purposes, but code it as treatment. Now, with the information blocking and other parts of the Cures Act coming into play, I'm hoping that that particular impediment is removed very, very soon. But But instead of exchanging data via point-to-point trust agreements and point-to-point technical connections, TEFCA has the promise of providing a single trust agreement and a new technical architecture to make that data exchange. I do think that there are going to be some barriers to get over, especially related to applicable law and how different states have, as I understand it, significantly different rules regarding how data can be exchanged, how it could be used, and all that good stuff.
Yeah. Rachel, I was going to follow up with you on that in terms of policy and regulatory requirements. And I think Mickey actually mentioned this as well earlier in regards to public health and the use case with TEFCA. So states have varying regulatory processes and requirements and laws on the books, and some of them definitely need to be modernized and potentially changed. So given some of those policies, regulations, laws, and how they vary across states, how do you see states potentially overcoming that, if necessary, to participate in a national framework like this?
Yeah, that's a good question, Debbie. I mean, I think it's not going to happen overnight. I mean, realistically, it just is not. It's going to take a long time. But I think the fact that TEFCA is there and that if the health department wants to use it and it sees it as a benefit, they're going to figure out a way to make it work for them. And I think there probably are going to be some changes at the state and local level as it relates to their laws and their regulations, and it may be modernizing them, it may be changing them. But I do think TEFCA, as we begin to develop the SOP, as long as we don't impede any of that, like we don't add additional things on top of what they already have to deal with, then I think we create the easiest path as possible for them to join.
Okay, so my question for all of you as we discuss this is, and I'll start with you, Adam, at the end of the row here. What do you think is as we're thinking about educating and motivating public health to participate and learn more and become involved in TEFCA, what is a key item we should be thinking about in terms of both respecting the fact that public health is a bit overwhelmed and has been a bit overwhelmed for several years now, and are going through processes to data modernize, IT modernization. So what is sort of that one thing we should keep in mind as we're dealing with public health and starting to write these standard operating procedures that would appeal to public health and suggest that you might want to participate?
I think it comes down to the simplicity of information. Right now, especially in public health, information has become a driving force. We need to, one of the buzzwords right now in public health is data-driven decision-making. And right now, I speak not only for Virginia, but some of the other states that I work with from an EMS perspective, we work in data silos. And as you open it up, and I mean, even small little snippets, participating with a national group and you release data nationally that people within your state see it, and it's, oh my God, I had no idea you had this. And all of a sudden now they won't. I think as you open up that idea and promote information as a decision maker here, that's going to be that pull for public health. It's down to anything from funding mechanisms, determining state budgets, determining workforce, strategic location of where services are needed. All of those draw back down to data and information. And health departments, and I can say this for Virginia as well as some of the other partners that I work with, they're starting to learn that there is data outside of the health department, and that is very valuable.
That's great. Kyle?
Yeah. Adam, I'll build on a little bit what you said. We've always heard the vast operating health information exchange. It's like the health department or those public health don't want to not have access to the data everybody else has access to, and then start their own collection system to do their own thing. And so I think having that bridge to say you're getting the same data as others with the other healthcare stakeholders, in the Commonwealth of Virginia or across the nation, is incredibly valuable to say we're all kind of in this together with this shared data, as opposed to not being able to get access and having to do your own thing.
Yeah, Mike?
I think from my perspective, it's important to remember that this is fundamentally a people problem. Technology exists. I mean, we're here talking about technology. We have been all day. But we can't just cobble together a technological solution and call it done. That's not going to work. Procedures, processes, they need to be formulated. They need to be put in place. But fundamentally, and this speaks again to Adam's comment about data silos, it's a people problem. People don't know that data exists. Why is that? Because other people didn't tell them that the data existed. And that gets back down to the whole trust issue in government that I was talking about too. That is fundamentally a people problem as well. So I think it's really important that we focus on people, focus on ensuring that the technological solution, the processes we put in place are things that our citizens across the country are willing to pay for and can make use of, and isn't something that's going to be so difficult to use that they just complain about it.
I think from a federal standpoint, I think our biggest challenge is going to be education, I think, in the sense of helping to educate, all the way down to the county level what TEFCA is and why it's important, and letting them know that it's there and that it's something that they can utilize, and they don't need to replicate something of equal substance in their state or locality. They can already use this to benefit themselves in their exchange. And I think too, I think just in my own, personal opinion, not ONC or federal government, but I think the other challenge is resources. There needs to be significant resources behind it in order for it to be successful, especially for public health.
I just keep going back to competition, and I'm hoping that if some organizations like the Commonwealth of Virginia and their public health agencies and HIEs step forward and decide to be pioneers in this with TEFCA, and then if we can repeat that in one or two other states, I think the other states will gradually feel that they're behind the 8 ball, accurate or not, and they'll step up and maybe have some urgency as well. Mm-hmm. So I see that as really exciting. We just have the initial chicken and egg conundrum that we've got to get past.
Yeah. So in the time we have left, I want to ask, the sort of title of our panel today is TEFCA and Public Health, what's in it for you? So what's in it for public health? So I'm going to start back with you again, Jay, and ask you, what's in it for public health, you think?
What's in it for public health? Mm-hmm. I think just the public good. It's good patient care. It's a healthier nation, and a job well done for them.
Mm-hmm. Yeah.
I would say it's probably interoperability with the healthcare system. Mm-hmm. Really.
So VDH has 5 strategic goals, only one of which I can remember off the top of my head. And that one is to be a trusted source of information. And I think that having something like TEFCA will help us achieve that goal.
Yeah, the framework's beneficial, and you don't have to rebuild the wheel. You've got a ton of work and effort's already been into this that you can leverage.
From an EMS perspective, I think it's duly beneficial for both the participants of an exchange as well as for the EMS agencies. Having more information ahead of time when you're going to treat a patient will not do it. The only thing it can do is improve patient outcomes.
Mm-hmm. Yeah, thank you. So I want to circle back with one more thing as I'm listening to you all, and I want to go back, Mike, to your statistic that you brought up, with 20% of people sort of thinking, respecting, agreeing with government. So this is a government program. Mm-hmm. how do you explain that to citizens of Virginia and have them build trust?
I don't know.
Yeah.
It's something that I wrestle with. So the context in which I was looking that up was I was part of a panel on AI and machine learning in the government space. And so paired with that 20% statistic is another pair of statistics. 71% of men and 79% of women, and I may have that reversed, but those two numbers are correct, they are concerned about what computers and especially AI and machine learning can learn about them. And so I think in order to help build that trust, we're talking about data exchange and freeing up data and making it more available. But it is also important to remember that every time we share data, that potentially poses a risk to the public, to our citizens, to our consumers. And it's, I think, key to be able to say, look, we're doing everything we can to protect your information, to not abuse your information, to not tie it together in ways that either you don't expect or that we didn't agree to or that are frankly inappropriate and potentially abusive. But how to get that message across and get people to believe it, if I knew that, I would not be sitting here. I'd be retired and on a beach someplace.
Well, I'm retired, but we still have to figure this out. Yeah, please.
To kind of take a different stance, even though we're both with the same agency, in sharing data and trying to earn that trust, we respond to a lot of data requests in the Office of EMS. And people want data. They want to know what's going on. And this is the general public. This isn't healthcare organizations. And very early on, we were very restrictive, very closed on that. And ultimately, our office got sued under that, under Freedom of Information. And, I argued before a judge in Virginia multiple times that this is healthcare data. It's not subject to FOIA. The judge and the legal system in Virginia disagreed with me. So as a result, we turned that around and worked with the Library of Virginia and the chief data officer in the Commonwealth. And now the EMS data set is available to the general public. There is a mutating algorithm that does small cell suppression and things like that. But anybody can go log in and look at gunshot wounds within a proximity of the house they're getting ready to buy now. Or, what is the survivability of a heart attack if you live here in Virginia? So making that data open and openly accessible was one of the ways we started to earn back that trust. The next piece, and again, this actually came from the TEFCA principles, is how do we start giving patients access to their EMS medical records? Mm-hmm. We are that record repository, we hold it, but we see that as kind of that next step.
Yeah. I would assert from that comment, Adam, and knowing this in other states as well, that there are sort of microcosms of TEFCA happening, versions of TEFCA happening now inside states and inside localities. And that is a good example of one that you just mentioned, an individual access, where the folks in Virginia can now look up. Now they're not looking up identified information, but right. They are looking up information that they've never had access to before. So I think doing what you're doing in the states and then elevating that to the national level is where we always say that public health really starts at the local level. Mm-hmm. It starts in the communities and then builds its way up in the national level. And I think that's where we're going to see the impetus of the concepts of TEFCA. I think one of the things we're working on in the standard operating procedure is looking at, and CDC has put these use cases forward, but looking at use cases for public health that really resonate with them, things like cancer registries and immunization registries and others. So those are the things that I think where we start, and that resonate with public health across the country, and we start building there. But I would say that those of you in health departments, you're already doing quite a bit of that work. So although I think we've made statements today that one of the challenges is that there's so much modernization that needs to take place, I think there's a lot that's been done in the states that we are starting to see as we are starting to work with you all on the concepts of TEFCA. So I want to sort of end on the note of you're doing great work. We just want to build on it at the national level, and really appreciate all of your input and your time today. I want to stop and see if there are any. We have a couple minutes left, and then stop and see if there are any questions from. I know I'll use the obligatory statement too, that we're standing between you and drinks, which is worse than standing between you and lunch. So. Can you see?
Okay, I'll try and be quick.
Oh, yes.
So I'm a healthcare researcher, and my group has tried to work with all the big data sets that we know of. So we've worked peripherally with opt-in and Truven data. We've worked with the Medicare 5% data file and with IQVIA data. And I'm just a little bit confused about how, these can exist even though they span different states. They're fully anonymized, and they exist and people can use them. So it seems like some of these barriers with legal barriers and state-to-state differences aren't there for those databases. The only barrier that my group finds is these are all really expensive. And so to access these big data sets, it puts it out of the purview of a lot of healthcare researchers. So can you just speak a little bit more to that about, how can these systems exist, in spite of the barriers that you talked about? It seems like some of those barriers may have already been solved, at least for these cases, for these data sets.
Right. Somebody want to take that?
I'll start out, and others can elaborate or correct or clarify. I think the big difference is that within TEFCA, at least for the initial sets of use cases, we're talking about data that has not been anonymized. So it is patient-specific data. And so that's something. And now, of course, someone can take that data and anonymize it, and then it can be distributed more easily. But the names and addresses and all that good stuff is an initial barrier.
I'll just add on this. So, and this really resonates more with my APCD hat on, because I'm assuming a lot of that is claims data. And so Jay made the key point about anonymized. But I know, like in APCD world, problem we'll run into is people will use those data sets because it's such a pain to request data across multiple state APCDs right now. But that is a problem we're actively trying to solve. I'll just plug that, like we're starting a pilot, I know, with Virginia, Maine, and Colorado to try to at least have a common request process where you can put one request in and get data from multiple different states, and then we're hoping that that could be replicated so that you've got public-grade pricing, I would say, on a multi-state research database to try to fill that void that does exist right now that's only being filled with commercial solutions.
Other questions? All right.
Hi, I'm Troy from the left coast, Contra Costa, California. You exist in this political context where a lot of public health data, your local politicians want to use it or know it. How do you, I don't know where I'm going with this exactly, but how do you provide them the data where this is a framework for actually like point-to-point, not aggregating it kind of framework?
How do you provide politicians data?
So I think
That's a great question.
good question.
We all want you to go first.
Maybe it's not a good idea.
So one of the things to know about Virginia, and I don't know how other states are set up, but we have a lot of local health districts that are fairly, in a lot of ways autonomous. And so the state level health department doesn't necessarily have to reach in and work with every locality and every county and every city that's requesting data. But where we do try to step in is say, look, local health department, you're strapped for resources. Don't forget, these things are available to you for, assistance. And also don't forget that, data suppression in terms of low counts and things like that is something that we need to keep in mind. And now when it comes to specific government entities, as long as data is not necessarily being publicized, we might be a little more free with some of the information that we give, because it is public health data, it is surveillance data, it is not necessarily subject to HIPAA restrictions other than security, but that's where I would start with that. And then that's probably a very long conversation after.
Mm-hmm.
Yeah, to go one step farther, one of the things we do to address the politicians, we learned, I learned five or 6 years ago, I don't give them raw data because they're going to screw it up. I generally run them through the epidemiological process, and they work with my epidemiologist and data scientist who provide them a report along the lines of what the data says, and it removes that political skew that they may be trying to apply to data. And that way we're not having to deal with protected, because I'm dealing with patient level data and patient specific data. This is the best way to where I don't, for one, we never want to tell a politician or a legislator no, but this way we can help them in the interpretation and maintain privacy.
Okay, so I'm getting the wrap up slide from Sully down here. But before we wrap up, I do want to do something. So if we want, Sequoia and Carequality would like to provide our appreciation and to one particular member of the panel, Rachel, Abby. Rachel is receiving the Government Leadership Award this evening from us.
Oh.
So Rachel has worked at ONC and with public health for many years. I've known Rachel for many years and worked in public health, but as we have worked over time with Sequoia, Carequality, et cetera, Rachel is one of those folks that is a go-to person for anything related to, at the ONC especially, anything related to knowing public health at the local level and being willing to step up on a panel at the last minute or be on a work group. She's also on our emergency preparedness information work group that we've been facilitating at Sequoia for about 2 years now, and has really been instrumental in just providing that government perspective with a public health hat on and with a really common sense approach to work. And I know that personally, she's always been available to brainstorm or ask questions, get feedback, what's going on in this state or that state, and how can we be helpful. So Rachel, on behalf of Sequoia, we really want to provide this Government Leadership Award to you, and thank you for all of your support and help over the years.
Thank you.
All right.
Thank you. So thank you again. Thanks to everyone on the panel. And I think someone is going to take over the stage.
Okay.
That way?
Up.
Oh, Alan's going to take over the stage.